Hello. Today I will be going over our presentation, the first part on response adaptive randomization method for clinical trials. Here's a brief outline of the information that's going to be covered today. In an introduction, what is response adaptive randomization and why should it be used? Implementation and considerations to be made, some pros and cons of the method. I'll talk a little bit about the balancing between ethics and statistical efficiency, which is a main point on this subject. When is response adaptive randomization useful? And then a brief summary at the end. What is response adaptive randomization? It is a type of adaptive design that involves the creation of an algorithm in order to allocate future patients based on the responses of previous patients. The algorithm takes into consideration covariates for balancing and involves interim analyses which alter the probabilities of future allocations. This is why it is an adaptive design, because it consistently adapts to the data coming in. In the case of response adaptive randomization, it is mainly taking the response of previous patients into consideration for future allocation. So here I'll go over a small example. In oncology clinical trials, the primary response outcome is usually a binary endpoint in which the overall response rate is calculated as the number of subjects who have objective regression of disease. These trials often have many treatment arms, which can include different dosing schedules. An example of this could be a product that is dosed once a day for 3 weeks on and 1 week off, or maybe once a day for 4 weeks on at a lower dose, which would be a continuous treatment, or even they have combination therapies, which combines different drugs in a single treatment. These arms often see different response rates, so response adaptive randomization would be able to assign a greater number of patients to the better performing treatment arm as the trial progressed, if there is an arm that comes out to have a better response rate. How widespread are response adaptive randomization trials? The response adaptive randomization method is a method that is rarely used in designing clinical trials today. The main reason for this is that this design technique reduces the power of the test, which I will talk about in greater detail a little later on in the presentation. This method has been more widely used in early phase clinical trials than later stage trials. On top of using responses to influence the assignment of patients to different treatment arms, some other considerations in the algorithm are general operation characteristics, such as enrollment rate and response delay, which are generally key factors in the success or failure of a clinical trial. For the previous example about cancer, these are two main considerations, as often it can take months to get response data for these patients, which usually involves a CT or PET scan to measure the lesions and other factors related to the cancer. For enrollment delay, it is not uncommon for trial recruitment to be multiple weeks between each unique subject. Many cancers and treatments are very specialized, so the target population is usually much lower than, for example, a drug used for diabetes or any more widespread disease outcome. So this slide talks a little bit about covariance balancing in the algorithm. Balancing covariates can be an important consideration to make when designing the response adaptive randomization algorithm. This becomes an important factor because the more that the patient allocation deviates from a purely random assignment scheme, the higher the chance that selection bias will be introduced to the trial. For trials with a low expected sample size, this can even be a problem in the simple randomization scheme. Different covariates can be given different control limits for p-values in the response adaptive randomization algorithm, which can be fine-tuned in order to rank the importance of covariates. Throughout the study, interim tests can be performed on the covariates to make sure there's no significant difference between the treatment arms in respect to these covariates. An example of how this consideration might be made is if many baseline characteristics are recorded for patients, the balancing of sex between groups may become more important than race or some other factors such as age. The flexibility of covariate balancing is wide and is often a major consideration in the use of adaptive designs. So this slide will talk about 4 major considerations of response adaptive randomization designs. The first major consideration of the actual design is type 1 error control. This involves the determination of stopping boundaries. For example, how many responses or failures must be seen for the trial to be stopped and the outcome to be determined a success or failure. This is an important consideration and is generally outlined in the protocol and statistical analysis plan of the clinical trial. The second consideration is type 2 error control, which is arguably the biggest consideration in a trial using response adaptive randomization design. This involves simulating outcomes and modeling the estimated number of subjects needed for the trial. Power is a huge factor, which I will go into a little more detail on later. This point should not be taken lightly before consideration of implementation of response adaptive randomization into a trial. As I've outlined, treatment arms may become imbalanced and recruitment rate might be low, which will also affect the power. The third step is trial monitoring adaptations, which involves conditional power calculations and interim adaptations throughout the length of the trial. One of the nice aspects of response adaptive randomization is that data is constantly being evaluated, and based on the performance of patients, the probability of allocation and algorithms can constantly be adjusted mid-trial and multiple times throughout the trial. The final step is the calculation of the primary outcome statistics, including point estimates alongside confidence intervals, as well as adjusted p-values. So why would you use response adaptive randomization? There are 2 main factors regarding the implementation of response adaptive randomization in a trial. These are ethical considerations and statistical efficiency considerations. As I will explain in the next few slides, these are the main factors in consideration when attempting to implement a response adaptive randomization design, and it is the most highly debated aspects of the design. Balancing these 2 competing interests is of the utmost importance when implementing this method. So here I want to outline some of the benefits of using the response adaptive randomization. There are some key benefits involved in using this method which should not be overlooked. The first benefit is it can increase the probability of success in the trial. If success is defined as hitting a particular number of responses or overall response rate, as is the case in many cancer trials, a design that allocates more subjects to the better performing group can help achieve this goal quickly. The benefit of this is demonstrating early success in particular treatment arms, which can lead to further exploration of a drug of interest. Because of this, it can even reduce the time to market for the drug, as the threshold of success for the primary outcome can be reached quicker, which can massively reduce the time it takes to get the drug onto market, especially if enrollment poses a significant issue for the particular disease of interest. The main ethical benefit, though, comes through the simple fact that a higher percentage of patients will receive the more effective treatment, and conversely, less patients will be treated with the less effective treatment. This is where the response adaptive randomization design really shines as compared to other randomization methods and non-adaptive design techniques, which don't take the response into consideration, and arms are often equally allocated. Here are some ethical considerations for this design method. Like I've said, response adaptive randomization allows for more patients to be assigned to the better performing treatment arm, which is obviously an ethical benefit. This is important as it increases the chances of the patient receiving the clinically better treatment. And a standard randomization scheme does not take this into consideration, so more patients are treated with less effective treatment than would be in the response adaptive randomization design. So overall, there's some clear ethical benefits to this design method. However, there are some drawbacks. The drawbacks of a randomization adaptive response adaptive randomization design should be clearly understood and should also be heavily considered. Over time, the better one treatment arm performs over another, the more skewed the assignment allocation will be in favor of the better performing arm. As statisticians, we know that this can greatly affect some important statistical aspects of the trial. The more imbalanced the treatment arms become, the lower the statistical power will become, and the harder it will be to make solid conclusions about the trial. Depending on the importance of statistical power in relation to the particular trial, this point should not be overlooked and is the main reason why response adaptive randomization designs have not been more widely implemented, and the main reason the methods are met with some major skepticism. Trials are often very costly per patient, and as I have stated earlier, it is often difficult to meet the desired sample size due to lack of resources or simply a lack of a large enough patient population. Sometimes you just can't find all the patients you need with a particular disease. The smaller the sample size, the harder it will be to compensate for the power imbalance caused by this design method. This also is affected by the primary response delay, and the longer the delay, the less effective response adaptive randomization can become. So now I'm going to talk about an example of what can happen with a response adaptive randomization trial. So the Michigan ECMO trial studied the effectiveness of extracorporeal membrane oxygenation in patients with respiratory failure. This trial utilized response adaptive randomization and used play the winner randomization technique, which greatly increases the chances of treatment assignment based on previous outcomes. This trial ended with a total of 12 subjects across 2 treatment arms. In the end, 11 patients were assigned to the new ECMO arm, while only 1 patient was assigned to the arm using the conventional treatment option. So a continuation of that. The outcomes of the different arms were stark. All 11 patients in the ECMO arm survived, while the single patient who was assigned to the other treatment arm had a fatal outcome. As you can tell, this is a very good outcome in terms of ethical benefit, as it is likely that a higher percentage of those 12 individuals would have died in a simple randomization scheme. It appears in this case, lives might have been saved through the use of response adaptive randomization. The controversy, however, of the results come with the fact that the final allocation ratio was 11-1, which does not allow for much of a statistical comparison between treatment arms. Could it have been more attributed to the chance that the only subject in the conventional arm died? It is unclear, given the extremely high allocation ratio and extremely low sample size of 1 of the conventional treatment arm. Some takeaways of this trial. The Michigan ECML trial is a great example of how a response-adaptive randomization design walks the line of ethics and statistical efficiency. The ethics and efficiency, and more specifically power calculations and considerations, are in contrast with each other with competing demands. Unfortunately, maximum efficiency and both of these aspects cannot be achieved simultaneously. So here I'll talk a little bit about efficiency versus ethics some more. So below, you can see a figure, and this figure displays how power changes over time with a fixed sample size as the allocation ratio of treatment A to treatment B increases. In detecting a difference at a significant level of 0.05, with the observed binary success probability of 0.32 for treatment A and 0.25 for treatment B, the power changes quite significantly with the ratio. As you would expect, the maximum power of around 83% occurs at a treatment allocation ratio of 1:1. As the treatment allocation ratio deviates from 1, a loss of power is observed. We can see that at a ratio of 3:1, located at the right-hand side of the graphic, the power lowers to about 70%, which is a 13% drop from the peak achievable power at this sample size of 1400. This next figure displays the overall number of failures of the trial based on the treatment allocation ratio. One line, the gray line, is based on fixed power, and the other line is based on a fixed sample size. As you can see by the gray line, if you want to achieve the same power as a 1:1 allocation ratio with a sample size of 1400, a larger number of subjects must be added in order to compensate for the difference in allocation ratio, meaning more subjects will fail treatment. The dotted line is conditional on the fixed sample size. Power is being lost as the ratio changes, and the number of failures is decreasing linearly as more patients are enrolled in the better performing arm, but it's not a very stark decrease. It's a slight linear decrease given the fixed sample size and the loss of power. I think these two figures display the struggle between ethical and statistical considerations very well. So, when is response adaptive randomization useful? Given the drawbacks that I've stated, there are still a few reasons for response adaptive randomization to be explored and implemented. For example, in early demonstration of efficacy, power may not be as big of a consideration as it is in the later stages of a trial. If population enrollment is not going to be an issue and the resources are available to enroll many subjects, response adaptive randomization could be a useful design. When positive patient outcomes are the most important, and when it is often the case that it's life and death, response adaptive randomization can make a lot of sense as well. On top of this, if the expected difference in treatment response is larger, the less patients will be needed to demonstrate a statistical difference in the treatment effects. So to summarize this presentation, response adaptive randomization is a highly debated trial design because of the hard to balance ethical and statistical efficiency trade-offs that need to be made. This is the main reason this design is not more common throughout clinical trials performed currently. It is an interesting alternative to simple randomization methods that are commonly used in clinical trials. Despite the obvious challenges a response adaptive randomization design poses, new methods are being devised constantly and has seen success in many of its applications. And here are the two references used in this presentation. Thank you for listening.